David will join us. I'll save my interesting case for last. All right, so this is just a nice, this is a case Julie sent me, but it's just a nice example of one of these. So this is a patient who has, oh yeah, I don't have the PA radiograph, that's right, but has this CT scan. And we've talked a lot about diaphragm things. And
Jeff, I don't see it yet. Is it on your main screen?
How about now?
Very good.
Okay. So CT scan, and you see there's this collection of fat in the lower right hemithorax. And so the question always is, you know, where is this coming from? Well, there's clearly a defect here, but and this is more of a resident type level case, but this is not a location of a Morgagni hernia or a Bochdalek. It's too anterior and it's too lateral. So when you see defects sort of in unusual locations, you have to think of old trauma, and rib fractures in that area would be helpful. We don't see those, but this patient did actually have a remote history of an injury. And these traumatic hernias are much more likely to become incarcerated, or whatever you want to call them. You can get a large thing. I think because the liver's in the way here, no bowel is sneaking in, but you can see the omental fat and the vessels going into it. And then on the sagittal, you see a nice, let's make it so right, it's the correct side, other side. Nice defect right there. So two anterior for a Bochdalek and two lateral for a Morgagni hernia. But in this case, there's potential the colon could come up in there and get caught. It's interesting though, diaphragm's fairly thick. Often it atrophies, but I guess the rest of it was fairly intact. So that case was from Julie. This is a neat case we had today. So this is a radiograph, and you can see there's a esophagram you get for free with the radiograph, and there's narrowing in the lower esophagus, this area, and then more contrast, but not a lot filling the stomach. And so that was done after the esophagram, but this was the original CT that was done 4 days before. This is an 88-year-old who has swallowing problems and was thought to have an esophageal mass at the outside institution. So it was, don't tell me I only have 33 images. Well, that is a real bummer. But anyway, you can see that the esophagus is filled with contrast. And there's also extensive asbestos-related pleural plaques and pleural thickening. Here's the lower. Yeah, they had trouble with their scanner, so it broke up into 2 scans. But you can see heavy plaque, and he's got barium in his lungs. But this is the interesting stuff. So there's still barium in the esophagus. So that was an esophagram with a fluid level on the outside, stenosis, and then sort of this funny-looking appearance. And we thought this might be a foreign body, but that's actually barium getting hung up at a stenosis, and then nothing emptying into the stomach. Esophagram was repeated here, and so here you can see a swallow. You follow it down, and that stenosis is persisting. And then there's sort of a shaggy-looking mucosa right at the vestibule, and then there's so this is the A ring, B ring, and then it eventually empties in the stomach. This is water-soluble contrast. Here's just a still shot. Stop this one. And you can see that persists, not on just on our CT, but also here. And then you can see the mucosal regularity. So they did an endoscopy, and there was no mass, but they did find esophagitis that was confirmed to be candida. He's, as far as I know, not immune suppressed, just older patient. And so we think this is just a stricture, a fixed stricture. So at the above the vestibule and just below it as well. But it was just neat to see it on multiple images. Just another example of the how fixed it is. And that's the important thing for these strictures, is that they're fixed. And when they went in there, they didn't see any findings to suggest it was a malignant stricture. Okay, David, you're here, so I'm saving this case for you. So this is a 79-year-old female who had this abdominal CT somewhere else, and you will notice there's some thickening around the aorta. And as we go into the abdomen, there's still thickening around the aorta. And then we have this sort of infiltrating soft tissue around the renal hyla and even extending into the kidneys. And then circumferential aortic soft tissue. And the outside radiologists favored this being Erdheim-Chester, which I thought was a great call. We don't see anything except this one area of the right ventricle, which and right atrium I can show you better. That's as far up as the scan went. So then the patient had an FDG PET CT, which I will show the two images. Hopefully it will fuse them up. I got to do it. Let's see. There we go. And of course, this is going to be metabolically active. It's not fusing. Oh, there's some button somewhere. Well, I'll just show the FDG images then. There we go. The right window here, and you can see there's this thickening and uptaking in the right atrium, and then all around the aorta, there's FDG uptake. And then as we go down in the abdomen, there's a lot around the renal sinuses. Interesting, nothing in the bone, and she had tibial radiographs that were normal. So let me show the cardiac MR now. I think we can see it. That's not the right sequence. Let me get the right one. This one, I think shows it. Yeah, so here in the right atrium. And Travis, I don't know if you've ever seen Erdheim-Chester in the heart. I didn't remember, but this is this thickening in this in the posterior wall of the right atrium, and that actually was the FDG avid portion, and on the post-GAD images enhances. But there's no real myocardial involvement in the left ventricle on the post-GAD short axis images. And then there's a small pericardial effusion. I looked at the lung bases on the abdominal CT, and there's no involvement of the lungs in this case. So Erdheim-Chester involving aorta, kidneys, and heart.
Yeah, that's sort of the case, and then I think I had one as well where it's involved. It often will involve the interatrial septum and just kind of wrap around the heart and involve like encase the right coronary artery as well, but not occlude it.
Okay. I should look at the coronary back on the. Let's see if we get define the axial stack here. Yeah. So here's the cine. Yeah. So we're kind of in that area near the groove. There's some soft tissue thickening there. So this is an Erdheim-Chester. She's older than I'm used to seeing, 79. All right, this is a 65-year-old with long-standing disease, and here's the radiograph. You see this calcifications at the hilum, and there's these reticular or linear opacities in the small right lung, some volume loss in the upper lobe, rightward mediastinal shift. And on the lung windows, you see the relative marked asymmetry of the vasculature, sort of nodular thickening along the pleural surface, or this fine along the fissures as well. And then these linear subpleural opacities lining up with the vessels. And when I show you the mediastinum, you'll see what this is all about. This is, you see this big mass at the hilum, the slow flow, nice smoke in the pulmonary artery, and lots of collateral flow in the azygos, hemiazygos system posteriorly. And then this filling defect actually extending into the superior vena cava with just a little collateral flow around it. So this is, and then big bronchial artery. So this is a fibrosing mediastinitis that's been rather long-standing. I think we have imaging that went back about 9 years or so with this SVC. This is the second time I've seen it actually invade the SVC because if you on multiplanars, it clearly looks like it's extending into the lumen. And in this case, you have all these are transpleural collaterals, presumably. But one of the more striking cases I've seen, you see this huge superior intercostal pulmonary vein. I'm sorry, a systemic vein going across into the hemiazygos system.
Wow.
Yeah.
And taken out the pulmonary vein and interstitial edema on the right side?
Yeah, so you see the inferior pulmonary vein is gone, and the right superior pulmonary vein is pretty much out. It is out. You don't really see anything. You see a nubbin. So yeah, and there is flow from the right heart, but you can see it's pretty diminished.
Yes.
So I suspect it's the collateral flow is out through the pleural collaterals, and the intercostal vessels are a little juicier on the right than they are on the left.
Jeff, is there splenic calcification to nail the histo? Yes.
2.
Yeah. Yay. It counts.
Yeah. Oh yeah, I forgot to show this. Yeah, the hot quadrate.
So what's the deal with the soft tissue? Is that more that's in the SVC? Is that more of an active inflammatory component?
Yeah, I mean, it's just a big, nasty fibrotic mass and it can grow.
Wow.
I guess it just triggers the fibroblast to come and build this fibrous mass. And so I don't know how it gets into the SVC. I mean, it looks like maybe it could be compressing it, but if I did I think it was what's wrong, a sagittal, it really looks like it's getting in there. Because we looked at this and talked about it for a while over here, and we're trying to sort out where the there you see all the collaterals, and the mass just kind of, there's not much left to it anymore.
That's interesting. If you biopsy this stuff, there's such stimulation of these bizarre fibroblasts and things like that it's mistaken for sarcoma. So it can look really nasty under the microscope. I think it's just growing. It's very stimulating. It's growing very fast.
Yeah, this has been long standing, but yeah, pretty much. I mean, it's almost always from histoplasmosis, but I have seen non-histo cases. But the ones that the histo tends to have more calcium has been my experience. This one doesn't have as much of a calcified mass. It's mostly soft tissue, but you can make out some calcium in it. But I like the smoke too. It's just this, you can see the difference between the left pulmonary artery and the right.
Dramatic.
Yeah, and also an older patient, which is pretty atypical for that. All right, I'm gonna let Travis and Howard run it from here, and I'll be listening in.
All right. Howard, do you want to show some, or David?
Sorry.
I need a little.
Go ahead, David, if you have. I can show some too afterwards.
I need some time to get ready, so please.
Okay. Okay. In advance of this, I posted this image on our kind of webinar-related Twitter account. So those of you that are watching on video, if you want to occasionally see some of these images before the webinar, you can subscribe. You can subscribe to Chest Rad Collab. But I posted these 3 images because they make a very nice theme. So I'll give you just a moment to look at that and look for the similarities as well as the differences among the 3 frontal radiographs. And I said, these cases make a theme. What is it? How are they different? And now I'll show you the cases themselves. So let me pick up the cases first in order. So this one is the first. I'll put up the lateral projection alongside. And the findings here are very typical and the usual findings of obstructive left upper lobe atelectasis. So when the left upper lobe collapses, it collapses superiorly, anteriorly, and medially. So on the frontal projection, we have super typical findings in that we have an ill-defined hilar region. At least there's ill-defined opacity there. The left main bronchus is slightly elevated. The left hemidiaphragm is slightly elevated. The vascular hilum, albeit partially obscured, is a little elevated. On the lateral projection, when one looks for the left pulmonary artery in its usual location, the opacity of it is not present there because it's been elevated and rotated. And then we also see this interface here between opacity and aerated lung. So these are the very typical findings of substantial obstructive left upper lobe atelectasis. And if we look at we'll put these up here, we can see on CT again, very typical findings where the upper lobe is atelectatic, moves anteriorly, medially particularly. And in this particular case, and this is a case from Tan Muhammad, the obstruction was ascribed to secretions and mucus, not a tumor, obstructing left upper lobe bronchus. And then again on the, I'll bring in the sagittal if I have the sagittal here. Maybe I don't. But typically with that degree of left upper lobe collapse, the lung collapses way anterior into the thorax, and this could really be hard to see because of where it's located. So that's the super typical, or typical left upper lobe collapse. I'll show you the next one, which is this one. Bring up the lateral alongside it. This one is strikingly different because the opacity is, on a frontal projection, much larger. And when you have the lateral projection, you can see again the interface between non-aerated, opaque lung and aerated lung, but it's far back from where it was in the previous case. And again, the other signs of elevation of the hilum, elevation of left main bronchus, and the presence of aerated lung here, which is the superior segment of left lower lobe. All of those findings are also present. So what distinguishes this one from the previous one is that although the lobe is airless, it still occupies a substantial amount of volume in that hemithorax. So for example, here you can see that it still occupies a lot of volume. There's a little bit of pleural fluid associated with it. And this is what I call, and used to be called at least, I think, drowned lobe syndrome. So in this particular person, I'm not quite sure what is accumulated in the air spaces, but typically with slow obstruction, drowned lobe, you have secretions, mucus, maybe so-called golden pneumonia with cholesterol in there. Sometimes the opaque and distended bronchi are visible, which I do not see here. And certainly there are no circumscribed areas of rounded lobe attenuation to suggest liquefaction from pneumonia, for example. But otherwise, just a variation on the theme of obstructive left upper lobe collapse with kind of a drowned lobe phenomenon. And this one is a patient with cancer. Do you folks still use that term sometimes, the drowned lobe, when appropriate, like in this instance?
I do.
For a radiograph, it looks like that. All right, and then the third one is this one. So this one is definitely the most unusual variation on that theme. So I'll put up the lateral projection alongside it. So here we have the usual signs of volume loss, like elevation of the hilum, left main bronchus. Unlike the other ones, we have opacity that is in the apical and apical lateral left hemithorax, which is different from the other. But you can see on the frontal and lateral projection that it's easy to ascribe this to the overexpanded superior segment of left lower lobe, but the opacity in the lateral and apical lateral hemithorax is unusual, to be sure, and then there are nodules here consistent with metastases. So what do we actually have in that apical hemithorax in this person? It turns out that, yes, the lung is indeed there. A portion of the left upper lobe is there, but also some pleural fluid. So the lung is collapsed anteriorly, as it should, but a portion of it here has been kept out along with the pleural fluid, presumably because there are adhesions in the pleural space, or adhesions that prevent this lung from drifting away there and going where it usually goes. So there is the atelectatic lung and a little bit of pleural fluid up there. So the best, what I intuit here is that there are probably adhesions in that pleural space, as we can see up here, that keep the lung up there. So this is a sort of a form of peripheral left upper lobe collapse, but it's partly peripheral and partly anterior where it should be. So you guys think that that's a reasonable explanation, that the lung is being kept up there by adhesions, preventing it from moving away medially?
So, Howard, the cases I've seen of peripheral collapse, I've seen them on the right as well, all had pleural adhesions, I think, as the most likely explanation. So that's what I thought in looking at these peripheral collapse patterns before.
Yeah. I can't think of another explanation in this particular instance for that finding, which is interesting. So yes, this is a metastatic cancer as well, primary lung cancer. Sorry, I think Travis, you may have said something.
Yeah, I agree. I like that explanation.
Yeah. Yeah. I think I may have seen this twice ever. It's quite unusual to have that one. All right, variations on the theme. The next one is interesting too, and I'll show you the chest radiograph. So the finding is not in the chest, but it is in the left upper quadrant. And this is the first time that I've seen this. So look at these calcifications related to the spleen and bring up a lateral projection. Make that big. And some of my colleagues have said, that have seen this before, said, oh, that's absolutely distinctive of SLE. And I didn't know that. But apparently that is an absolutely characteristic pattern of calcifications in SLE. I don't think it's known why it happens, but then I started looking for case reports, and this is just an example of the case reports one can find showing this phenomenon. Have you folks seen a case like that? This is my first, as best I remember.
No.
Of this.
We've seen a lot of cases of calcified sickle cell disease where you get splenic atrophy and calcification that can look similar to that. But obviously this patient doesn't have sickle cell disease.
Yeah, my patient does have SLE and renal failure. So the diagnosis of SLE is definitely a thing.
So is it the lupus or is it the renal failure?
Yeah, I would wonder about the renal failure.
The case reports that one can find, like this one, are in patients with SLE. I don't think they necessarily have to have renal failure. It's just, if you just Google exactly that, you'll see a whole bunch of case reports with these kinds of calcifications, and I didn't know that. And my abdominal colleague said, yep, that's classic. Just like that. No differential diagnosis. I didn't see this. So there you are. All right, Travis, those are mine.
Cool. David, are you ready?
I think I'm ready here. So,
Okay.
okay, so this case was sent to me by an oncologist who encountered this bizarre chest CT from outside hospital in a patient of his with myelodysplasia. It's about to be seen in our, stem cell transplant clinic. So there's this ground glassy consolidation. It seems to be fairly peripheral, but with a little rim of sparing at the very last minute here. So, almost subpleural, very peripheral, apically predominant, I think. And then there's denser consolidation and pleural effusion in the bases. I think a different process in the bases. So I would have no idea what this is. I would suspect it might be something along eosinophilic pneumonia or organizing pneumonia sort of pattern. It doesn't look like any infections I'm familiar with. I have seen peripheral distribution of ground glass in H1N1 influenza. I know that was reported in the outbreak in 2009 as a common finding. It resembled eosinophilic pneumonia being peripheral. So does this ring a bell for anybody? Is this a familiar pattern?
No, not particularly. No.
Okay, so what was recovered here on, let's just check it out here on coronal, just for fun. Again, it's that apically predominant peripheral, but not immediately subpleural.
And some of it's very nodular, like discrete little nodules, which would make you think maybe something infectious rather than just an organizing pneumonia of another cause.
Good point. Yeah, it does have a peribronchiolar central lobular component to it.
Or could it be more than one thing simultaneously, which is always a conundrum in these kinds of patients sometimes.
That's
They may
right.
not have one diagnosis. It's hard.
So this fellow was not neutropenic at this stage, but his cells might not be working properly because of his myelodysplasia. And this turns out to be pneumocystis. So this was pneumocystis PJP. I think it was recovered bronchoscopically. I haven't delved into the history yet. So I've never seen PJP look like this before, but you know, I'm still learning. My birthday is this week. So
now that you mention it, there is a form of pneumocystis that's given the name granulomatous. I think
Wow, look at that radiograph.
Yeah, maybe that form.
okay, so here's case 2. This woman with awkward bilateral pneumothorax, and it looks as if there's some diffuse interstitial lung disease lurking in there. So a young woman, I think around 30. So what do you think? Fairly uniform.
Lamb?
Lamb. Should be lamb. Okay. So another boring case of lamb. So here's what it looks like on CT.
Wait a minute.
We
Little unusual.
ELCH, maybe.
why do you like LCH? I mean, the cysts are worse than the bases, actually.
That's true. But sometimes rules are meant to be broken.
Yeah.
The cystic bases are very irregular, and the lungs are very hyperattenuating.
Right.
And
It's too messy. Everybody agrees it's too messy for lamb, correct? I mean,
Yep.
it seems a white abnormality, not just the black abnormality.
yeah,
So I was wondering whether this might be, light chain deposition disease or LIP or something like that because of the basal predominance of the cysts and the general messiness of everything. And she's a young woman, of a population, I think, that has a higher rate of some collagen vascular diseases. Okay, and it turns out to be, on biopsy, it's LCH. So then our pulmonologist collected some smoking history. She smokes a few cigarettes a day, but she smokes marijuana every day as well. So there's more than one flavor of smoke that's getting into her lungs. And I'm not aware of marijuana smoke being a risk factor for LCH the way tobacco smoke is, but I haven't looked that up specifically. So if Jeff's still online, Jeff has been researching these complications of marijuana. I just wonder if LCH is one of them, that might be contributing, or maybe this is just all tobacco. So surprising, unexpected for me, diagnosis of LCH. The one thing I roundly rejected was LAM. I considered LCH, but I didn't like that because of the basal predominance of the cysts.
So, David, I know there's been just LCH has been seen in marijuana users, but as far as I know, it's supposed to look like LCH.
Yeah.
This is crazy. And it was pure LCH. So it wasn't like mixed, more, macrophage type stuff.
Even, DIP type of.
Whatever you want to call it, smoking related lung disease. Because something's not, it doesn't explain the dense lungs.
It doesn't, right? The dense lung.
Right.
And also, I think some of this looks more like emphysema than cysts too.
Was it a wedge biopsy or was it a transbronch?
You will have to research. I think here's what they did. They went in for a pleurodesis, and the pulmonologist called me and said, should we get a lung biopsy? And I said, absolutely, because I can't figure out what this is. And so they biopsied the lung when they did a VAT. So it was a VATS biopsy.
Yeah, because some of the stuff posteriorly, right there in the right lower lobe, looks like airspace enlargement with fibrosis.
Yes.
Yeah.
So it brings up there may be multiple pathologies here.
Yes, I mean,
what they see under the microscope. Yeah.
LCH, emphysema, and some,
smoking related.
I think that would be a good explanation and put it all together.
Maybe she smokes more than she lets on, and we're seeing multiple manifestations of bad smoker's lung.
Well, And what's everyone's thoughts? You know, you read in the literature that whatever 5% of Langerhans occurs in non-smokers. I mean, is that referring to the more systemic variants that you see often in younger patients, or is that just you think there's secondhand exposure or other things that we don't know about?
It's both, and I seen one case in a non-smoker, but he was, I think, like 19.
Yeah.
Had a bone lesion.
Right. So that would be called Huntschuler-Christian. You know, that's
Right.
one of the systemic histiocytoses.
And they're more likely to have a monoclonal expansion as opposed to a polyclonal. I'm not satisfied with this case, David. It bothers me.
Well,
right, I'm going to go back to my work and let you continue.
We definitely have LCH, but whether it's, I think it's probably combined with other manifestations of cigarette smoking, and who knows how many different substances she's not letting on to smoking. So here's another young woman with diffuse lung disease, and I think this woman had pneumothoraces, and she has a abnormal chest CT, and you know, she came in with a diagnosis of LAM, and we see these cysts, some of which have thicker walls and some bizarre shapes, and very nice sparing of the costophrenic angles. And here are the little bit of thicker walls, there's distortion of some of these cysts, and there are a few little white objects floating around too. So I figured that this was much more likely to be LCH, nice distribution, and so that's the working diagnosis is LCH. And if she has not, they did a VEGF and that was negative, so that sort of turned them away from LAM. But our pulmonologists here, you know, have favored that this is LCH, and she is a cigarette smoker. So she also smokes some marijuana. So she, in this state, it's practically, there's a law now. You have to smoke marijuana. It's not only legal, but it's mandatory. So she has stopped smoking everything. She doesn't want to have pneumothorax again. And so I don't know how much of this stuff can clear up. Surprisingly, I have seen some of the cysts in LCH resolve when people are, when they've stopped smoking. So I used to think that the cysts were permanent, and in most cases they don't go away, but I have seen, I think, 2 cases where the cysts actually regress substantially. So there's a chance that some of these at least could go away. So we don't have path proof on this, but I think the appearance of the cigarette smoking, the nice distribution is quite good for LCH on this one.
Yeah, excellent for that. I would say that with certainty. There's no hesitation about it.
And the accompanying white blobs are also good for that.
Yeah.
Then
and another nice thing about that case, just for teaching purposes, in the old days we used to talk about the presence of extensive lung disease in which lung volumes are preserved, at least static lung volumes are preserved. So if you see a lot of lung disease, but you don't see signs of restriction, like in this patient,
right?
Think, among other things, of PLCH. It's one of the disorders that does that.
LAM as well. So I would put the 2 L's there. LAM and LCH are famous for that, and sometimes sarcoid. Okay, LAM and LCH are the big ones because with the cysts, you're actually expanding your lungs. Okay, so this is a 15-year-old boy who presented with this opacification of the right hemithorax, and it looks as if there's a convexity interfering with his airway there. And indeed, here's his right upper lobe bronchus, which is encroached on by this vigorously enhancing mass here, central mass, very nicely enhancing there, and then enhanced lung distal to it. On coronal, you also see this central enhancing mass here.
Oh,
so I figured this was a carcinoid, slam dunk. And they cored it out. At this point, they haven't done a definitive resection, but they cored this out and restored very good lung volume and re-expanded his right lung very nicely. And this turns out to be a mucoepidermoid tumor. It's not a carcinoid. So I wasn't aware of that tumor being as vascular as this. So I think the vascularity here really pushes me more and more, toward carcinoid for this. Not only statistically should it be a carcinoid, but in terms of the enhancement, it should be a carcinoid, but it wasn't. It was a mucoepidermoid. And that's based on the tissue, a substantial amount of tissue that they cored out. What do you guys think? Have you seen mucoepidermoids blush like this?
No, I mean, one doesn't see many of them in a career because they're unusual, but I can't remember one.
Yeah, I can't remember them being that vascular. They're not, sometimes the squamous cells will be a little bit lower necrotic. I always think of them just intermediate.
Right.
Oh, quite unusual. And by virtue of age, too.
Right.
Yeah, just bad luck. Or
Gosh.
bad genes.
Okay, guys, those are the cases I wanted to show.
All right, great.
Thank you.
I'm going to take over here. You'll see my screen in a second. Let's see.
Nobody can see you scream.
Huh. All right. Well, this is an interesting case, and this is in 2013. This is a man who, you can see, that is 71 years old at the time. And in 2008, he was diagnosed with CLL, and he was started on rituximab. And around that time, or shortly thereafter, he developed a lot of mediastinal lymphadenopathy. And when you see his lungs, you'll see that he has nodules in a perilymphatic distribution. There's a lot clustered along the bronchovascular bundles, and then a lot along the pleural surfaces and the fissures. It's a little bit more upper lobe predominant. So he had undergone a bronch at some point and was diagnosed with sarcoid. And it's uncertain whether it was a sarcoid-like reaction or just sarcoid that was, unmasked or even unrelated to the CLL and his rituximab therapy. But around this time in 2013, he started developing pleural effusion. So I don't have any of the more remote studies. And you can see in 2013, he just had a right pleural effusion. There's a little bit of pleural thickening. It wasn't really getting bigger over time. They did several taps, and it was always exudative, but nothing cellular in it. And you can see that there's the pleural thickening is fairly smooth. And I think this is on a more of a delay from an abdomen and pelvis CT. And then fast forward to later in 2014, he starts to develop a small pleural effusion on the left. And then 2016, he gets a PE study, and this pleural effusion on the left is much larger. And you can see he's got more volume loss on the right side. And so I think this may have been just iatrogenic, the pneumothorax here. But he was referred to our sarcoid clinic. Well, and one of the questions was, what's the cause of the pleural effusion? Because you can see he's still got nodules in the calcified lymph nodes. And they ended up doing a VATS and an open pleural biopsy on the left.
Before you go on, Trav, don't you think the pleural membranes are very thickened and lobulated, thickened, as in maybe pleural lymphoma-like? Could be.
Well, right, and so that was the question, and that was what I was getting at. So they did a biopsy between somewhere around here in 2016 because the left side, the pleural effusion was getting worse. I mean, there's not a lot of pleural thickening that you see, but unfortunately, this is just a PE study anyway with the timing, so you're not going to see a lot of enhancement. Yeah. But there's definitely the perilymphatic nodules in the lung. So the question was, is this lymphoma? Is it tuberculosis? Is it something else? And what's the guess? Anybody?
For the right side, I certainly would have thought pleural lymphoma as a.
The right side's just been chronic and is smoldering. The left side, actually, the pleural biopsy was all sarcoid of the pleura. So,
wow.
So plaques. Pleuritis with non-necrotizing granulomas throughout the plaques. This was actually done at Stanford and then sent here too. So at both places, the conclusion was that this was sarcoid. And all of the tissue all of the micros been negative. And so our sarcoid expert here, that's most of what she sees, this is the second case in 20 years she's seen of pleural sarcoid. And it's the first one I've encountered. I found one recent case report of pleuroparenchymal sarcoid, and they talk about how the incidence on old radiograph studies was less than 1%, of cases of sarcoid had pleural involvement. And then with ultrasound, they were finding pleural effusions in a third of patients, but pretty unusual manifestation of sarcoid.
I think this is really going to be a sarcoid-like reaction, don't you? I mean,
yeah, probably. It's been going on for 10 years though, but I mean, I guess
I think that's actually good for the sarcoid-like, well, the atypical sarcoids. That's, for instance, that's good for borreliosis, is to have lymphadenopathy that persists for years and years. So I don't, frankly, you shouldn't hang a lot on that, because that's just my personal take on it. I don't really have statistics to back that up.
yeah, no, but it's just, this is the first time I've seen a chronic pleural effusion that's attributable to sarcoid, whether it's, you know, a sarcoid-like reaction or, you know, since we don't know what sarcoid is in the first place.
That's right.
But yeah, so this case report had the same thing, this granulomatous inflammation, non-necrotizing granulomas. And they theorize in this that the idea is that you just get chronic inflammation and the effusion as a production or as a result of the granulomas in the pleural space. But I don't know, one might expect to see it more frequently then, because all of these patients have perilymphatic nodules.
Yeah, it is puzzling.
But Howard, that's what I was thinking first too, is lymphoma, especially given his history of CLL.
Oh, sorry, I was confusing. My comment was directed towards the right side when I said I was just.
Well, yeah, even that side too, right? Because it was a little bit more nodular, or at least kind of lumpy bumpy. Yeah.
Yeah, very unusual to have. Yeah.
So this is an interesting one. I saw the radiograph last week, or I guess earlier this week. You can see this is a patient who's had a extended right hemihepatectomy, and he had these little branching dense things in his right lung. And I thought at first these were actually little surgical clips or something. It turns out they're not, and they're related. But you know, I immediately went to look at his spine to see if he had had a vertebroplasty done, thinking these could be little embolized methyl methacrylate. He had not had that done. But what I will show you is I'll go back and you'll see on pre-op of everything, there's nothing in his lungs. I'll show you the venous phase, and he has this large right intrahepatic tumor, which was a cholangiocarcinoma, an intrahepatic cholangiocarcinoma. So between these two, you'll see that at this, and unfortunately it was done in an outside hospital, but he underwent right portal vein embolization. And now, lo and behold, all of these things have shown up in the lungs. And what's really interesting about this is, you know, portal veins don't really connect to the systemic veins. And so this is some sort of portal vein embolization. And this was done in an outside hospital. And the note didn't say what they used. I'm guessing this is lepiodol or some sort of, synthetic material that's dense that they used for the embolization. But the question is, how the heck did it get into the lungs? One of my body colleagues thinks that if they did this percutaneously, that they must have created a portosystemic shunt with their needle, and that's how this embolized. I don't know. I can't find anything in the literature specifically related to portal vein embolization causing lung emboli, but you can see that's what all of these are, that these clearly trace out to the pulmonary arteries, and the temporal relationship is perfect. So I'm wondering.
Do you see anything heading toward the cava from that that material in the? Does anything get down toward the cava?
David, that's a great point. Look at that right there. I wonder. I mean, I don't know. That could be just a branch of a portal vein, but that one looks like it's going awfully close, and could even be in a hepatic vein, couldn't it?
Right. So, you know, I think when you stick a needle through the liver like this, you're probably creating a little potential fistulae between the different venous systems there.
Yeah, that's a really good idea, and I bet that's what that may be right there.
Is that heading upward? Let's see. Are we going up?
Well, it's headed. I'm scrolling up, and it's headed right to where the IVC should be. And but I guess it was an iatrogenic, or maybe the tumor had created the connection.
Good point.
But yeah, no, that's a very good observation. And I hadn't, because usually when you see vertebroplasties, you can see it in the azygos vein and the paravertebral plexi. But Yeah, so this is a portal venous embolization with resultant emboli to the lung of whatever this is, Lipiodol plus or minus something, some other permanent material. And it was all done elsewhere. Apparently, he did have one episode of dyspnea after this. With these patients, they always admit them to monitor for sepsis as a complication of the hepatic vein or the portal vein embolization anyway. But thought that was another interesting macroscopic embolus case.
Yep.
And Howard, this is thanks to you. You had me go digging through our teaching file last week because this was something that I hadn't seen and hadn't thought about since the old days of board review.
Mm-hmm.
This radiograph, though, tells the whole story. This is a VP shunt. And then we see, as you commented on and showed that case last week, these little rice-like calcifications oriented along the axis of the muscles, probably a bigger cigar-shaped calcification here, probably one in the sternocleidomastoid muscle there. And this guy is interesting because he was a contractor. He lived and worked in India for like 30 years, and a couple years ago was diagnosed in India with some sort of what they thought was idiopathic hydrocephalus at the time. Here is the subsequent MR that he had, and you can see all these little cystic spaces along the, centrally here, some of them along the periventricular areas, and he already has the VP shunt at this point. But this, of course, is all cysticercosis with this is these cysts, I guess, in the lung or in the brain is Rasmose, RACEMOSE, neurocysticercosis, and then he just had the calcification. So this is the only one that I could find or the best one I could find in our teaching file. So I just wanted to show that since it reinforced the point to everyone, so that hopefully you'll remember it. And then I went digging. I found this. This is his. They checked his cysticercosis level. His antibody level was through the roof. And but I found this image from the New England Journal, and yeah, neither of our cases unfortunately can compete with this one, but it's a pretty spectacular case of it. So that's included too.
Excellent.
All right, this one I'm going to go to a little bit of an eye test. And this was credit to one of our MSK radiologists who picked this up on a scoliosis series. And I'll show you, see, we can put this side by side, and I'll right here on the frontal view, and then I'll get the lateral view if I can, right there. And yeah, you can see that somebody astutely picked up this mass in the middle mediastinum. So it's a little anterior to the vertebral bodies. What's interesting, though, is this vertebral body right here. There's a little bit of a compression fracture. I think that's actually what this was done for, because the patient was having pain. And you can see this mass, in a location that we would expect some sort of, foregut duplication cyst, maybe esophageal tumor. It's a little more posteriorly than just in the inferior, like in the subcarinal space. So maybe a lymph node. They didn't have a known primary tumor. But you can see there's this big tumor. It's soft tissue attenuation. It's either eating into or extending out of the bone. More likely it's eating into the bone from the mediastinum here. And so they went and took this thing out. They worked her up for myeloma, thinking maybe this was a plasmacytoma, lymphoma, etc. And this turned out to be a leiomyosarcoma, primary of the middle mediastinum with bone invasion. So,
sarcoma.
Yeah. So, I think we always, or actually they didn't take the whole thing out. They just did a biopsy because she's elderly and she's also Jehovah's Witness. But yeah, so I think we see sarcomas occasionally pop up everywhere in the chest, and they tend to be big and ugly looking tumors. So
this was not esophageal then? It was
no, I think it's separate. The esophagus is up here. Yeah, that was good point. I think there's a fat plane preserved from the esophagus right here.
Yeah.
Wow.
Yeah. So just of smooth muscle and OS in the middle mediastinum.
Interesting.
All right, this one. I'll keep going unless anybody else has cases they want to show.
That's great. Now you're fine.
I think this is one that I found this one in follow-up. You know, we've talked some about intrapulmonary lymph nodes, and I'm a big fan of trying to blow off nodules whenever I can, and or at least explain them away as intrapulmonary lymph nodes. And this is one I saw way back in 2015, and you can see there's this little nodule right here that, you know, it's a little ovoid shaped. It is, I would say it's juxtapleural, or it's at least within a centimeter of the pleural space, but it's not the typical triangular configuration. And more importantly, I did an old study from a couple years ago, from a couple years prior to that, where you can see that it had gotten much bigger. So as a result, we didn't pass it off. I don't remember if this patient had a history of a malignancy or not. She may have had an underlying cancer, but you'll see a couple years later in 2017 that has now become this, and now there's no doubt that that's not just an intrapulmonary lymph node. And so this actually ended up being an adenocarcinoma of lung primary when they resected it. It was followed one more time, and then eventually you can see now it looks more like a typical adenocarcinoma. But yeah, I can't remember if she had another primary that we were following or not, but it's like I said, I like to try and explain away things as intrapulmonary lymph nodes wherever possible, but this one we couldn't. It also shows the value of having old studies to compare to, even if they're abdomen and pelvis CTs.
So the growth of it is quite indolent, isn't it? What is the time period in total about?
Oh, 3 years.
A couple of years. Huh?
Yeah.
Indolent growth.
Yeah, but you can see here on this sagittal that I don't know, it's just a little ratty edges, but makes me a little.
I think of a metastasis before I think of a lung primary, wouldn't you?
Exactly.
I mean, yeah, but the immune cytochemistry was consistent with lung origin, huh?
Yeah. Pulmonary adenocarcinoma.
Okay.
So, yeah, it's a little scary. All right, let's see. And then we've got time for a couple more here. This is one that, this is a patient that in 2016, this is a patient who was being listed for transplant. I don't remember if it's liver or renal transplant, but they came in with, or got transferred in with this. And the suspicion was this was called a spiculated mass, question primary lung cancer. And of course, that got everybody worked up in the pre-transplant workup, since she wasn't, obviously, if she's going to be a renal transplant recipient, they wanted to know about that. But I think what's interesting about this is it has tons of little satellite nodules.
Yes.
And these are centrilobular, if not frank tree and bud nodules that are adjacent to this thing.
Absolutely. That's interesting.
Yeah, so
that changes one's mind.
Yeah, exactly. So then a couple months later, you can see she has a follow-up, and it's pretty much unchanged. Maybe some of these nodules are a little bit more confluent in the satellite nodules, that is. And then she underwent a PET during that time. It was hot, no surprise, and they hadn't been able to get anything via bronchoscopy, so we biopsied this, and it turned out to be tuberculosis.
Tuberculosis. I was going to go cocci, but
yeah, well, that's what. Right. Oh, come on, my preview is dying here. Yeah, no, that's what we would have thought too. I mean, we thought it was going to be some sort of fungal infection, but this actually turned out to be this. If I can show it, get it to show here that it was actually tuberculosis in this case.
Wow.
Yeah, so and I was trying to look for this, like what the utility of satellite nodules is in the diagnosis of infection versus a camera or cancer. Sorry, here you can see there was nothing during the no acid-fast bacilli, but it did grow or they identified TB by DNA probe. Yeah, but I can't find anything in the literature about how supportive or the presence of satellite nodules is for infection. I think we all know it's much more suggestive, but there's no good hard data that I know of. Do you guys know of any?
Yeah, I don't know about data, but I think we've all seen it, and we've all showed multiple cases over the years of lesions where you have material in the lumens of bronchi and bronchioles, and we think of infection. I still apply that rule.
Yeah.
In my own work, generally.
Because that's right. That's what we told them too. That when we first saw this patient, I told them I thought this was probably going to be infectious, like cocci, some sort of granulomatous infection. just based on the morphology. And you can see this is after months of treatment too. This was after the biopsy the next year, and it really hasn't decreased in size that much at all. But she's been on treatment, so presumably it's getting better, but you never know.
That's curious.
Yeah, and then this is just a quick ICU. I know Howard in particular likes to show devices. I kind of like this one just because we have not one Impella device in the LV, but you have a second Impella device in the inferior vena cava out into the pulmonary artery. So this is a patient who had both right and left ventricular Impella devices at the same time. I think this is the first one of these that I've seen with a patient that had biventricular failure. And there's actually a CT to correlate with it too. So if you need to add that to your ICU collection of devices, this one shows both of them at the same time.
Yeah, very nice.
So, yeah. So, okay. Well, it's about 1 o'clock here, so I'm going to stop there. And
So,
I don't know.
Travis, you remember your absent left pulmonary artery eruption? I showed that case along with some other cases of mediastinal rotation.
Yeah.
So-called. I was making the point that we shouldn't call this herniation of the lung, but we should call it mediastinal rotation. So it fit right in with these other cases I showed in Long Beach last week, and I'm sure that's why I got a high rating on that lecture. But thank you for letting me.
Oh, of course. So, all right, guys.
Thanks,
Well,
everyone.
I will remember to never call it herniation either, unless
Okay.
I'm doing it, unless I know you're in the audience. So.
Well, let me make another point about that. Jonathan Chung had talked about mediastinal shift before, but if
Yeah.
you look at the way the mediastinum moves in that setting, it really rotates around the descending aorta. It's as if the descending aorta is the hinge, that's the fixed point, and then anteriorly it swings way back and forth through several degrees across the mediastinum. Across the anterior chest wall. So I think rotation is really the best concept for that, rather than shift and rather than herniation.
Yeah, that's a good point. Yeah, in basically even in the cases that Howard was showing of lobar collapse, you're getting more rotation than you are shift, right?
Yeah.
Good thought.
All right. I like
Thanks,
it.
everyone.
Take care, guys.
Bye-bye.
Okay. Bye, everyone.
Thanks, guys.